I'm going to be talking today about it's not just the removal of cow's milk protein. So these are my conflicts of interest, and obviously today's symposium is sponsored by Nestlé Health Science. So I'm sure all the clinicians in the room are well aware of what a cow's milk allergy is, but just to quickly recap, it's an immune-triggered reaction to the protein in cow's milk. So that's the whey or the casein, and this can be cow's milk, fresh cow's milk, cow's milk-derived products as well. And broadly speaking, there's three main sort of classifications that we see in clinical practice. We've got our IgE-mediated allergies, non-IgE, and then a combination of both of these. The difficulty arises that actually many of these symptoms, particularly with our delayed cow's milk allergy, are just also symptoms that we see in pediatric behavior. So what infants do, they cry, they regurgitate, they can be a bit constipated sometimes. And so actually this leads to lots of overdiagnosis and potentially underdiagnosis as well. So the prevalence of food allergy or cow's milk allergy is still a little bit controversial, and that's because it's really difficult to diagnose these conditions, particularly the delayed allergies. And so it's reported in the literature around 1% of cow's milk allergy, but actually parental reporting is much more, about 10%. And I'm sure in our clinics and our practices, we feel that there's a lot of cow's milk allergy, or maybe symptoms that are suggestive of cow's milk allergy. But to diagnose these delayed cow's milk allergies, we really need to make sure that we're doing the 4R process. So removing that protein, replacing it with something suitable, so that might be advising mum if she's breastfeeding on a milk-free diet, or moving to a hypoallergenic formula. After a set period of time, usually 2 to 4 weeks, reintroducing that protein to see if there's a relapse in symptoms and confirm or exclude cow's milk allergy as the trigger for the symptoms that that infant is having. But as I've said, overdiagnosis continues to be an issue. So even if we suspect an infant has cow's milk allergy, breastfeeding absolutely remains the optimal way of feeding an infant, and this is in all of the guidelines, and it should be the first choice of milk for an infant if the mother can breastfeed, if they want to, and there's no medical reason as to why they shouldn't receive breast milk. And it's recommended from birth until 6 months of age exclusively, and then alongside complementary feeding until 2 years of age. And this isn't just benefits that we see for the baby, we've also got sort of maternal health benefits. We see lots of social and bonding benefits between the mum and the infant. There's economic benefits, breast milk is free, so you don't need to buy formula, and the healthcare systems don't need to fund that. And then also there are some environmental benefits, such as not having to use lots of plastics if you're feeding the baby directly from the breast. And so from a nutritional perspective, breast milk contains pretty much everything that an infant needs. So this is sort of a schematic or a diagram of the breakdown of mature term breast milk, and obviously between each mother this will vary slightly. But you can see the largest component is water, and then the next would be carbohydrate, which is predominantly from lactose. And this is kind of stable throughout breastfeeding, and that keeps the osmotic pressures stable as well. You've got your protein component of the breast milk, which is a combination of whey and casein, with the early lactation being a higher percentage of whey, and then around 50-50 as we move through the lactation journey. There's different types of fats that we find in breast milk, and again, this varies throughout the feeding. So the Hind's milk will have slightly more fat compared to the fore milk, and in general, breast milk contains between sort of 68 to 70 calories per 100 ml. Some of the micronutrients are a little low, which is why, in the UK in particular, we have sort of standard supplementation of certain vitamins in exclusively breastfed babies. But it's not just the macro and the micronutrients that breast milk provides for infants, it's also these non-nutritive factors, things like your human milk oligosaccharides, your HMOs, growth factors, hormones, immunological factors, cytokines, chemokines, glycins and mucins. So there's loads of benefits from breast milk for the baby and for the mum. If we're thinking about how we might diagnose cow's milk allergy, particularly non-IgE mediated allergy, this is a publication from ESPGHAN, which was published last year, I believe. And we can see that breast milk is on here and recommended as the first line in the management of cow's milk allergy, the process of exclusion and reintroduction to confirm that diagnosis. The first line formula that's recommended for infants who can't breastfeed or the mother chooses not to would be an extensively hydrolyzed formula, or actually a hydrolyzed rice formula that has just been added into the ESPGHAN guidelines and also the Jackman guidelines. And the process would still be the same, so in a process of exclusion followed by reintroduction of that cow's milk protein to confirm the allergy. And then in those severe cases, if there's anaphylaxis, FPIEs or EOE, we would go to an amino acid formula as a first line. And so what options do we have for these infants who are not breastfed, or through parental preference or due to supply issues? And hydrolyzed formulas can be categorized into sort of 5 sub-formulas, really. We've got our partially hydrolyzed formulas, which are not appropriate in cow's milk allergy because the proteins are not broken down enough. We've got extensively hydrolyzed formula based on cow's milk protein. We've got amino acid-based formulas. We've got soya-based formulas. They're not actually available in the UK anymore, but they are available in Europe. And rice-based formulas. Again, they're not available everywhere, but they are available in some countries in Europe and in the UK. So the decision to decide which formula we need to use for an infant is based on their symptoms, nutritional composition, and thinking about whether there's any residual allergenicity of these hypoallergenic formulas. So before kind of thinking about which formula we'll use, we need to kind of make sure we're understanding about how these formulas are produced. And so the aim of a hydrolyzed formula is to break down the peptide lengths into a shorter length so that the body doesn't recognize it to trigger that allergic reaction. And if we're thinking about the makeup of cow's milk protein, we've got 2 main types. We've got your casein and your whey. And within those, there's a number of different allergic fractions. And each of these fractions have different Dalton sizes. So that's the molecular weight of the protein. And these proteins contain epitopes, and they're either conformational or linear. And it's these epitopes that have specific regions that can trigger the allergic response and the allergic reaction. So for a reaction to occur, the immune system must recognize these epitopes, leading to the antibodies binding, which then triggers this inflammatory cascade, triggering the allergic symptoms we see in clinic. So as I've said, to make a formula an extensively hydrolyzed one, we need to break down these peptide lengths, so this reduces or alters the allergenicity. And broadly speaking, there's 4 main processes that are involved in breaking down these peptide lengths. We've got heat treatment, which mostly affects the conformational epitopes, particularly the whey proteins, but not so much the casein. We've then got enzymatic hydrolysis, which again cleaves those polypeptide chains, mostly denaturing or destructing the sequential epitopes, and this is both the casein and the whey that are impacted. And then we've got enzymatic hydrolysis under hydrostatic pressure, and then finally ultrafiltration. And broadly speaking, all the products on the market use this process. But since we kind of first classified extensively hydrolyzed formulas, there's been obviously many advances in techniques and processing. So actually, are these formulas as hydrolyzed as we maybe once thought that they were? So I suppose this poses the question, are all extensively hydrolyzed formulas the same? And yes, in theory, they're all labeled as extensively hydrolyzed formulas. They all meet the EU recommendations in terms of macro and micronutrients, and that's very closely and tightly governed. But they do differ in terms of certain additions maybe that are in these feeds or what they're made up of. So they can be different protein types, so they might be a whey or casein. We've got the residual protein length or the peptide size, the carbohydrate source, so whether they contain lactose or whether they're a lactose-free product, what the source of fat is, so is it predominantly MCT or LCT, or does it have a higher percentage of one of those? Is there any additions like probiotics such as LGG, and other additions like prebiotics such as human milk oligosaccharides, galacto-oligosaccharides, and fructo-oligosaccharides as well. So one of the major differences we see in these extensively hydrolyzed formulas is the peptide length or the Dalton size. And as I said before, the Dalton size is the molecular weight of the protein or the peptide. And at the moment, there's not actually a consensus as to what the definition of an extensively hydrolyzed formula is. And so the American Academy of Pediatrics define EHF as where most of the nitrogen is in the form of free amino acids with the peptides less than 1.5 kilodaltons. BSACI suggests that this is the greatest percentage of peptides under 1 kilodalton. And then EAACI recommend that these products are tolerated by at least 90% of infants with cow's milk allergy. So it's difficult for us to say this is absolutely 100% an extensively hydrolyzed formula. But does this make any difference for us in clinical practice? And if we know this information, would it change which formula we might recommend for these infants? And so we all have come across those children in clinic that appear to still react to an extensively hydrolyzed formula when we start them on it. And this is actually backed up from data that we see from the Europreval study, where they showed that actually less than 50% of infants had a symptom resolution when moved on to an extensively hydrolyzed formula. So we need to understand a little bit further whether the peptide length is a contributing factor to this. So this was a study that was conducted by Nestlé Health Science, and Claire will go into it in a bit more detail shortly. But what they did is analysed all the commercial extensively hydrolyzed formulas on the market at the time, and they detected any residual protein that was left. And they used this sort of arbitrary cutoff for allergenicity of greater than 1,200 kilodaltons to suggest if they had a higher amount of allergenicity. And as you can see, there was a number in group 3 that had significantly higher numbers of peptide lengths that were greater than the 1,200 daltons. They also looked at whether there was any residual beta-lactoglobulin present in these formulas. And we can see that actually there was quite a significant number of these formulas, particularly the ones with the higher peptide lengths, that still had some residual cow's milk protein present, which I suppose poses the question, is this the reason why some children maybe still react to these infant formulas? Another factor that make extensively hydrolyzed formulas variable is whether they've had lactose added into them or whether they're lactose-free. And so if we think back to the picture where there was the composition of breast milk, you know, carbohydrate containing lactose is around 7% of the nutritional provision from breast milk. And this is a naturally occurring prebiotic, and so we want to try and mimic breast milk as much as possible when we're feeding an infant with infant formula. And this is important because infants who have allergy or allergic conditions have been shown to have a different microbiota, lower levels of bifidobacterium and lactobacilli. And so the aim of this study was to look at a formula that had lactose added to it and compare it to one that didn't have any lactose added to it, and see if this had any impact on the microbiota and also the metabolome. So the metabolome is anything that is produced by the bacteria in the gut, things like short-chain fatty acids, for example. And what they demonstrated in this study is that the addition of lactose was able to modify the gut microbiota of the allergic infant. So they increased the total number of bifidobacteria and lactobacilli, and decreased the bacteriotides and other less favorable types of bacteria within the GI tract. It was also associated with an increased total concentration of short-chain fatty acids. And this is important because we know short-chain fatty acids have a direct impact on our immune response and sort of tightening up the epithelial cells within the gastrointestinal tract. Another benefit about having lactose added to a formula is that it appears to also increase the absorption of certain minerals. So this study looked at the absorption of calcium and zinc in particular in 2 formulas, one which contained lactose and one which was lactose-free. And the presence of the lactose appeared to increase the absorption of the calcium, but it didn't have any impact on the zinc. Not to say that the product that didn't have any lactose in meant that there wasn't adequate calcium. There was. It's just that the uptake was slightly better when there was lactose present. I also just want to highlight that in the ESPGHAN guidelines that I've mentioned before, they've also added some information about using formulas with lactose present. So historically, often people or clinicians would go for an EHF that didn't have any lactose in it if a child had suspected cow's milk allergy. But ESPGHAN suggests that we don't really need to do that. We should only be choosing a lactose-free formula sort of temporarily to kind of get on top of diarrhea or very loose stools. And then when we're done the challenge and confirmed the allergy or not, we actually want to put the lactose back in. So as infant formula continues to evolve, the companies obviously want to make this as close to breast milk as possible. And so HMO, or human milk oligosaccharides, is a sort of a naturally occurring prebiotic in breast milk. It's an indigestible carbohydrate, which means that it acts as kind of a fuel source for the bacteria in the gut, helping them to repopulate or populate and thrive. Human milk or breast milk contains over 200 structurally different HMO that we're kind of aware of at the moment. I'm sure there's much more. And at the moment, there are a number that are able to be synthesized to be added into infant formula with the aim to make that as similar to breast milk as possible. And this is particularly important in the first 1,000 days of life, so that's from conception to around age 2. We know that the infant microbiome continues to develop until around 3 years of age. And actually the gut or the bacteria within a breastfed infant is predominantly populated by bifidobacterium strains. And HMO is highly selectable by bifidobacterium, so if you give it to these types of bacteria, they continue to thrive and reproduce. They then sort of ferment the prebiotic, so the HMO, producing the short-chain fatty acids, so albuterate, acetate, and propionate. And this is important because it inhibits the inhibits the harmful bacteria or pathogens that we don't want. As I've said before, it kind of tightens up those epithelial cells, preventing sort of harmful infiltration of any pathogens into the GI tract and then into the body as well. So one of the main drivers of the formula companies is to add this HMO to the product with the aim to try and make the microbiota and the metabolome as similar to that of a breastfed infant as possible. And so in this study, infants were fed a hydrolyzed formula that had 2 different types of synthesized HMO added to them. And they were looking at the population of the bacteria within the gut at early enrollment and then when the formula was introduced a little bit later. And what they showed is that the addition of the HMO to the formula enriched the bifidobacteria, so increased the bacteria that was more similar to that of a breastfed infant, and actually slowed the maturation of the bacteria. And that's helpful because it means that it doesn't match that of a sort of a more of an adult type microbiota earlier on in infancy. Interestingly, they saw if the HMOs were introduced earlier in infancy, so before 3 months of age, they actually had a higher population of bifidobacteria. And so they've kind of hypothesized that this actually could prolong the window for sort of early immune modulation for infants if they're exposed to HMO via formula if they can't breastfeed. But we want to know, I suppose, as clinician, is it safe to give infants formulas with additions into them, so such as prebiotics? So this was a study looking at 2 different types of formulas, HMO combined EHF formula, and then an EHF without any HMO added in it. And what they found is that it was well tolerated by both patient groups. So nearly 100% of patients tolerated these formulas without any issues. And so they've suggested that the hypoallergenic formulas with the additions of these 2 types of HMO are safe for use in children with cow's milk allergy. I'm a dietitian, so I want to make sure that they're obviously growing well, and I'm sure you're all interested in that as well. I won't talk about these studies individually, but just to show you some graphs. This is looking at a comparison of the 2 formulas, so an extensively hydrolyzed formula, one with HMO and one without. And we can see that actually their weight for age Z-score, their length for age Z-score, head circumference and BMI were appropriate in both of those types of formulas and actually followed a very similar trajectory. So just to sum up before Claire takes over, breast milk remains the recommended mode of feeding for infants with cow's milk allergy. If they're not able to receive breast milk and we know they have cow's milk allergy, we suspect it, we should be recommending an extensively hydrolyzed formula or alternatively a hydrolyzed rice formula, and that's now first line on a number of different guidelines. We shouldn't be avoiding lactose in cow's milk allergy. This could positively support the gut microbiota and aid absorption of essential minerals as well. Not all EHFs are the same. That's in terms of peptide length, any residual cow's milk protein, and this could potentially impact clinical outcomes and tolerance. And the addition of HMO may be beneficial to support the microbiome to be more similar to that of a breastfed infant. It supports adequate growth and it's well tolerated by these infants. Thank you.